Bismillah Rahman Rahim. Assalamu alaikum dear students. I hope all of you are fine. I welcome you all on this online teaching system. Today we are going to discuss a very interesting topic. Let's have a look on the scenario. First of all, a 64-year-old architect complains of left-handed tremor at rest. Alright. So which interferes with his writing and drawing. He also notes a stooped posture, a tendency to drag his left leg when walking and slight unsteadiness on turning. He remains independent in all his activities of daily living. Examination reveals flat facies, hypophonia, and a resting tremor, and mild rigidity in all the limbs and impaired rapid alternating movements in the left limb. Neurological and general examinations are otherwise normal. What is the likely diagnosis and how should he be managed? So students, I hope by the time I have read the scenario, you must have guessed what is the cause of this condition. So it is basically what we're going to discuss today is a neurodegenerative disorder, and that is called Parkinsonism. All right. So we are going to discuss a brief pathophysiology of Parkinsonism, then its classification, and then the treatment of Parkinsonism, their drugs, adverse effects, their mechanism of action, and their contraindication. So today's topic is drugs used for the treatment of Parkinsonism. Parkinsonism is also called paralysis agitans or shaking palsy. It's a progressive neurological disorder, right? So ये नहीं है कि it's reversible. It is always going to progress, and it is disorder of muscle movement. What are the features? As we just discussed in the scenario, it is resting tremors, muscular rigidity, bradykinesia. And what is bradykinesia? It is slowness in initiating and carrying out movements, postural and gait abnormalities, and mask-like face. And mostly the patients over the 60 years of age. But there are exceptions to it. In even early stages, a person can get Parkinsonism. So let's have a look on the etiological factors of Parkinsonism. So basically, there is destruction in the dopaminergic neurons in the substantia nigra. All right. So what is happening that there is reduction in dopamine actions in the corpus striatum and basal ganglia that are involved in the motor control. That is why the patient is having these types of signs and symptoms. So the other factors are aging. It may have a genetic predisposition, oxidative stress, and various toxins can also cause Parkinsonism, and defective energy metabolism can also lead to Parkinsonism. So what is our strategy? So what is basically happening in Parkinsonism? There is an imbalance between the cholinergic and the dopaminergic neurons. All right. So either there is excess of cholinergic or either there is deficiency of dopaminergic. So what is our aim? Our aim is to correct the imbalance between the acetylcholine and dopamine. So how do we classify the drugs for Parkinsonism? First of all, we are going to target those drugs which affect the dopaminergic system, and secondly, the drugs which are going to affect the brain cholinergic system. So let's have a look on the drugs which affect the dopaminergic system. Number one is dopamine precursor, which is levodopa. It's a very important drug from examination point of view as well. Its mechanism of action, its contraindication, its adverse effect, everything is very important about this levodopa. All right. Then we have peripheral dopa decarboxylase inhibitors, in which we have the main drug, which is the carbidopa and benzodiazepines. Then we have dopaminergic agonist like bromocriptine. Then we have pergolide and pramipexole. Then we have another drugs like MAO-B inhibitors, in which we have salicyline. MAO-A inhibitors, we have already done that in antidepressants, and MAO-B inhibitors MAO is the monoamine oxidase enzyme, which is responsible for the metabolism of various dopamine, serotonin, norepinephrine. So B is basically responsible for dopamine metabolism. So if we inhibit the metabolism of dopamine, of course, there is going to be increase in the level of the dopamine. So our main target is to increase the level of the dopamine. So we have selegiline in MAOB inhibitors, then we have COMT inhibitor, that is catechol O-methyl transferase, which is also an enzyme which is responsible for metabolism of this dopamine. Then we have entacapone and talcapone in this COMT inhibitors. Then we have dopamine facilitator, which is imantadine. Imantadine, students, we will cover over here, as well as we'll be covering it in antiviral. So imantadine is dopamine energic drug, but it is also having another characteristic which is antiviral, which is specifically used in influenza. So the first part of the classification is the drugs affecting the dopaminergic system. And the second part of the classification is drug affecting the cholinergic system, because as we discussed that there is an imbalance between dopamine and acetylcholine. So in acetylcholine we have central anticholinergics, which are basically blocking the acetylcholine. And if you have a quick recall in the ANS when we discussed about the therapeutic classification of anticholinergic drugs, so this was the drug group in which we were repeatedly asking you that name the anticholinergic drugs which are used in Parkinsonism. So these are the drugs: trihexyphenidyl, procyclidine, bipridine, and benztropine. All right, so this is just the revision of the these anticholinergic drugs. Then we have also antihistaminics. Students, remember at this point, since antihistaminic means it can be H1 blockers and or H2 blockers. Since if you recall, H1 blockers were particularly used in the condition of this allergic condition, right? And H2 blockers were used in the treatment of APD, which is acid peptic disease. So over here we are talking about H1 blockers, because H1 blockers, when we discuss about them, we said that they have additional anticholinergic properties as well as alpha blocking activities. If you recall the question which was also asked in the exam, and I repeatedly told you that this can be asked, okay, what are the advantages of second generation antihistamine over the first generation? So second generation does not mean H2 receptor. Second generation means H1, but the better generation. So in the better generation, they are lacking the effects on the CNS. How? Because they are not affecting the acetylcholine, they are not affecting the alpha 1 effects. So the over here antihistaminics, we have orphanedrine and promethazine. So regarding the classification, so the key point is we have to give the drugs which are either increasing the level of dopamine or either they're decreasing the level of acetylcholine. So the main prototype drug for today's lecture is levodopa. As I already mentioned, a very important drug. So regarding its mechanism of action, let's have a quick look on what it has to say. Dopamine itself does not cross the blood-brain barrier, all right, but its precursor levodopa is transported into the CNS and is converted into the dopamine in the brain. So this is the key point to remember. And large doses of levodopa are required. Why? Because much of the drug is decarboxylated in the periphery. So students, remember this thing. When a drug has a very low bioavailability, what are the three strategies by which you can increase the bioavailability of the drug? So note down over here, the question for today's assignment is how you can improve the bioavailability of levodopa. So give 3 reasons. All right. So we'll be discussing in the lecture what are the methods by which we can improve the concentration of levodopa to be acted in the CNS. All right. So this is the diagram from Lippincott, and it is clearly showing how dopamine is formed in the body and how levodopa is transported into the nerve terminal. All right, so let's have a look. If you recall from the ANS, tyrosine is converted into dopa, and dopa is converted into dopamine, and it is stored in the synaptic vesicle, and then it is excreted out, and then it acts on the dopamine receptor. All right, so it is tyrosine is basically transported to a transporter, and we have various enzymes at this stage like tyrosine hydroxylase and dopa decarboxylase. Over here, if we look, the fate of administered levodopa. So once you have administered levodopa, what is happening? If you see this large arrow, it is 90% of the drug is metabolized in the GIT and in the peripheral tissues, all right, and only a few percentage of the dopa is reaching into the CNS. So this is how the levodopa being given to a patient is very less percentage is reaching into the site of action. So how can you improve it? You can give another drug along with levodopa, which is carbidopa, as we just discussed in the classification. It's a dopa decarboxylase inhibitor. So if we give levodopa along with this carbidopa, then it breaks down of the levodopa is minimized. The metabolism of levodopa is minimized. So it will leading to two effects. First of all, more of the dopa is going to reach into the CNS, and secondly, the undesirable side effects which were seen because of its metabolization in the periphery, they are going to be less. So this is how you improve the bioavailability of levodopa. You can combine it with carbidopa, and there are two other mechanisms. Of course, you can answer that very well. So now we move on to our second drug, which is the carbidopa, and as we just saw in the diagram that it's a dopa decarboxylase inhibitor, and it also does not cross the blood-brain barrier. But what does it do? It diminishes the metabolism of levodopa in the GIT and peripheral tissue, and it increases the availability of the levodopa in the CNS, and it also decreases the dose of the levodopa by 4 to 5 fold, and of course it also decreases the severity of side effects. So lots of benefits of combining carbidopa with levodopa. So this is a very important question from examination point of view. So what is the rationale for combining carbidopa with levodopa? So this all points are the answer to this question, and note down, it's a very important university question as well. So regarding the pharmacokinetics of this levodopa, it is rapidly absorbed from small intestine, but it is more absorbed when there is empty stomach, and extremely short half-life, and fluctuations in plasma concentration lead to fluctuations in motor response as well. So this is the point to remember. If there is too much fluctuation in plasma concentration, then the motor response would also be varied. So it improves bradykinesia, however, it does not cure Parkinsonism. So I just told you earlier that it's a progressive neurodegenerative disorder, which means that it is a lifelong process and is not going to be cured. They are going to be on and off periods of the improvement of the patient. So two important points which are wearing off reaction or end of dose akinesia, as the name is indicating indicating wearing off reaction or end of dose akinesia. Akinesia means there is no movement or lack of movement. ठीक है, तो wearing off phenomena क्या है? It is responsiveness fluctuates and gradually decreases with time, and it reflects the progression of the disease. All right, so you have to remember it reflects the progression of disease, and clinical response also fluctuates. But in some cases, it may be related to timing of levodopa. So when a patient is having Parkinsonism, he is taking levodopa for a long period of time, then of course what happens, there is the end dose phenomena, which is when the fluctuation in the levodopa plasma levels occur. When there is less level of levodopa, then of course there would be decrease in the motor activity of the person. Then there is another terminology which is called examination point of view, and in which we say that unrelated. There is another very important terminology which is called drug holidays. So what is drug holidays? As the name is indicating, drug holiday means discontinuation of the drug for 3 to 21 days may temporarily reduce toxic effects and rarely affect response fluctuations. If we stop the drug for the time being, for a short period of time, and then we restart the drug, then there is going to be improve in the patient's symptoms. But the side effect is that increases the risk of aspiration pneumonia, venous thrombosis, and pulmonary embolism. However, if we add COMT inhibitors, the motor fluctuations can be improved and in the same patients. So nowadays the concept of drug holidays is not much appreciated because of its risk of aspiration pneumonia. But previously it was seen that if we stop levodopa for a short period of time, it can lead to improvement in the signs and symptoms. So regarding the pharmacokinetics of levodopa, remember one thing: whenever there is motor fluctuation, the patient will experience tremors, cramps, and immobility. So another very important point regarding the pharmacokinetics of levodopa is that you should avoid taking levodopa with a diet which is very high in protein. Why? Because levodopa has to enter inside the nerve terminal through amino acid transporter. So if you take a very meaty meal, then it is going to compete with the transporter. So levodopa should be ideally taken on an empty stomach or 45 minutes before a meal. And of course, the withdrawal from the drug also must be very gradual. Do not stop the drug at once. With that, we end today's part 1 on anti-Parkinsonian drugs. And don't forget to submit your assignments on your respective WhatsApp groups on time. Thank you very much. See you with the next part on anti-Parkinsonian drugs. Allah Hafiz.